My name is Chido Dziva Chikwari, and I will be presenting findings from the BGAP study. The title of my presentation is Index-Linked HIV Testing for Children and Adolescents in Health Facility and Community-Based Settings in Zimbabwe. Testing of HIV-exposed children remains suboptimal. However, late diagnosis is often associated with chronic complications, and effective strategies to identify children with undiagnosed HIV are urgently needed. This study had three main objectives. The first objective was to investigate the uptake and yield of HIV testing offered to children living in the households of HIV-positive individuals. The second objective was to investigate the factors associated with uptake of testing. And the third objective was to investigate the uptake of community versus facility-based testing for children. The study was conducted in two provinces in Zimbabwe, namely Bulawayo and Matabeleland South. Over 12 months, research assistants were based in 6 urban and 3 rural clinics, and they offered indexes with eligible children in their households 3 options to test children in their homes of unknown HIV status or of a known HIV negative status that is greater than 6 months. Indexes could choose between facility-based testing by a provider, community testing where a lay worker could come to their home and test the children, or provision of an oral HIV self-test kit so that they could test their own child at home. Over 12 months, we screened 9,927 indexes and identified 2,870 indexes with eligible children in their households. Among them, 62.3% tested at least one child in their household. From these indexes, we identified 6,062 eligible children, and 68.3% of those children were tested, and 39 children were diagnosed to be HIV positive. Our HIV prevalence was therefore 1.1%, and our HIV yield was 0.6%. When we evaluated factors associated with testing, we found that any caregiver who had to pay to access a health facility was less likely to have their child tested. When we assessed child factors associated with testing, we found that older children were less likely to be tested when compared to children in the 2 to 5 year age category. When we evaluated choice, we found that facility-based testing had the highest uptake at 66.5%, followed by community testing by a provider, and then caregiver testing at 5.6%. We note, however, that 470 caregivers who initially chose facility testing had their children later tested in the community. In conclusion, the HIV yield in our study was low compared to findings in similar settings. Barriers to testing, such as cost of transportation, continue to prevail, and there's a need for HIV testing strategies that target older children. We conclude that community-based testing strategies are feasible and can be used to improve the uptake of testing for children. I would like to acknowledge the following people, and thank you for listening to my presentation.